Good afternoon. Welcome to you all. My name is Nisha Jansen. I'm a nurse and I have worked in TB control in the Netherlands for more than 20 years. Since 2008, I'm a senior nurse consultant working for KNCV Tuberculosis Foundation based in the Netherlands. Since November 2019, I'm the program lead of the Nurses and Allied Professionals subsection from the Union. This subsection aims to provide a forum for nurses and allied professionals to promote discussion and networking. Today, I'm chairing this session together with my co-chair, Surinder Tamni, and she will introduce herself.
Hello and welcome to everybody. My name is Surinder Tamni and I work as a senior nurse in the National TB Unit, Public Health England in the UK. And it's been... Welcome to everybody. My name is Surinder Tamni and I work as a senior nurse in the National...
The title of the session is What Person-Centered Care Really Means. I checked some definitions and I want to share with you a part of the definition of WHO. This includes that patient-centered care is providing care that is respectful of and responsive to individual patient preferences, needs, and values. In this session, we have 6 presentations around this theme from different parts of the world. We are going to start with a presentation of Mr. Moses Arinaitwe about how the patient pathway analysis method is used in the development of the National Strategic Plan in Uganda. Then we go on with another study from Uganda about TB-related stigma presented by Nikki Davis. Jennifer Zag will continue with a presentation about support for TPT for people on ART in Zimbabwe. Sirisha Papineni will present about the integration of mental health service in TB care in India. Our 5th speaker, Lindy Dixon Hall, will speak about models of care for patients who are treated for MDR in South Africa. And Ali Zhao from China will close the presentation series with an overview of the implementation of a supportive care package to improve treatment adherence for MDR patients. After the presentation, there will be room for questions. You can post your questions during the presentations in the Q&A box on the right-hand side of your screen. Choose the 4th button, so not in the chat. You can rate the questions so we have an impression of your interest and we will take this into account in answering the questions. Now we can start with the first presentation.
Thank you very much for the opportunity to share with you some of our findings at the Union Conference, Advancing Prevention. My name is Moses Arinaitwe. I'm a medical doctor working with the National TB and Leprosy Program in Uganda as a monitoring and evaluation technical advisor. I had declared no conflict of interest, and the subject at hand is using patient pathway analysis to align care seeking and service delivery in development of Uganda's person-centered national strategic plan. We have come out of development of our national strategic plan, which is currently running from 2020, 2021 to 2024, 2025. And this is the team of people I worked with at the program from Uganda National TB and Leprosy Program, USAID Defeat TB, KNCV, Tuberculosis Foundation, and Linksbridge. So the methodology we used here was to map care-seeking behavior using the demographic health surveys, and then mapped that with service availability at the different levels of the country's health facilities. And we used the patient pathway, which is the graphic shown at the top, showing how a patient flows, since this is person-centered service delivery. And it looks at before a patient develops symptoms with TB in the community, and then they go on to develop TB through exposure. They don't have symptoms initially, and then they develop symptoms and start to seek care. A diagnosis is made, and then they're treated, supported, and then eventually declared free of TB. And then the cycle goes on again. And so we looked at the categories of care seeking by level of health facility, right down from the village health team going up to the national referral hospitals. And in Uganda, we have a village health team at the very grassroots level who is an individual going into the community. And you have a health center too, which is a health post, which has 1 or 2 health staff and a few OPD facilities. And then level 3 with a lab and a few more health staff and inpatient services, usually maternity. And then the level 4, which has a theater, medical officer, and then a level 5, which is a district hospital, and then higher regional, and then national referral, which are super specialized hospitals. And using the patient pathway analysis software developed by Linksbridge, we mapped this with the service availability using our reports, our program reports, WHO annual reports, TB prevalence survey, our DHIS2, which is the platform for reporting and the service and readiness availability. And using this evidence, we mapped the 2 questions of care seeking and service availability. This is the graphic display for the patient pathway analysis that looks at facilities by level in the first column, if you like. And then the next column shows the care seeking patterns. The third column shows the coverage of diagnostic services. And then maps that with the coverage of diagnostic services at the initial visit. And the 5th column shows the coverage of treatment services from first line and second line drugs, and then the access to treatment services at the first visit, because that is important. Some of our studies have shown that people tend to come and get a diagnosis after their 3rd visit. So first visit of initial care seeking is what was important to analyze as well. And this is a summary of what we found, that 58% of people with symptoms relating to TB initially sought care from the private sector, and yet only 2% had the capacity to diagnose TB. If I can quickly go back, you see in the blue here, 42% at private for-profit health facilities, 42%, and then at the drug shop, which is basically a kiosk where people go to get drugs off the counter. And those combined give about 58%. And then in the brown, we see about 42% seeking care initially from a public facility, and most of it is in the lower public facilities. And we see 2% in the 3rd column of private facilities had diagnostic capacity. And most of the diagnostic capacity at the initial visit is in the public health facilities, which is about 35%, and a small 1% in the private health facilities. And then for treatment, for diagnostics, we found that the lower level public facilities in the brown had 90% availability of diagnostic capacity. That is mainly microscopy, and 2% for gene expert facilities. And whereas 95% of high level facilities could diagnose a TB, had the appropriate equipment, microscopy, gene expert, and the others, only 5% of the population initially sought care from these. And only 36% of the population had access to diagnostic and treatment services at their first visit, and most of this in the public sector. And so from these findings, we realized that there is a significant misalignment between initial care seeking and service delivery or service availability. And we used this evidence to inform our national strategic plan, which among other things enabled us to focus on engaging the private sector, creating awareness, and then strengthening of screening and diagnostic access at lower level health units. We feel that once we expand the diagnostic capacity at these levels, it will enable us to give access to services where most of the people are seeking care from. And also strengthening all these sectors in terms of diagnosis and treatment access to engage also the private sector where people are seeking care from, and the lower level facilities to have both capacity but also referral mechanisms to be able to help the people access care where they are seeking it from and where they need it from the most. So these were our findings, and we definitely highly recommend the patient pathway analysis for countries to evaluate their gaps in alignment of care seeking and service delivery in the bid to have person-centered care, because people vote with their feet, and they are going to look for services where it's most convenient to them. And in our case, it was at the lower level facilities and the private sector. And I would like to acknowledge the Ministry of Health Uganda, other ministry departments and agencies in the country who work with us in a multi-sectoral approach to ending TB. Our implementing partners, including but not limited to WHO, PEPFAR, CDC, and USAID, and USAID Defeat TB in particular, KNCV, Tuberculosis Foundation, and Linksbridge.
Hi, good morning, good afternoon, and good evening, everyone. My name is Nikki Davis, and I'll be discussing findings on TB-related stigma in Uganda from a mixed method study that looked at perceptions of TB patients, TB healthcare providers, and community members. So first, I just wanted to start with a little bit of background. As many of you know, Uganda is one of the 30 high-burden countries for TB-HIV co-infection, and it has an incidence of about 200 TB cases per 100,000 population, as well as about a 65% TB coverage rate. So in terms of TB stigma, we know from past research, both in Uganda and in other countries, that it's a really complex and challenging issue, which has shown to be a major barrier for TB interventions. And it's really clear from these studies that understanding both kind of the breadth and scope of TB-related stigma from multiple perspectives is absolutely essential for efforts that are aimed at improving the quality of TB services. So I just wanted to quickly kind of walk you through our main objectives for the study. We really, first and foremost, we really wanted to be able to describe TB stigma from the perspective of not only TB patients, but also TB health workers and the communities in which TB patients reside. And beyond that, we were also aiming to try and understand kind of the potential effects of TB stigma on patients' health-seeking behavior. So for example, delay in care seeking after the onset of symptoms, or even concealment of TB symptoms or concealment of a TB diagnosis, so things like this. So in terms of the methods, this study was nested under a larger activity, which was the Quality of TB Service Assessment, or the QTSA in Uganda. And again, because we knew that TB-related stigma was a really complex issue, we specifically designed a mixed method approach, which with the hopes of kind of gaining a deeper understanding of stigma from multiple perspectives. And this approach included a survey of over 350 TB healthcare providers, as well as about 500 TB patients, and also included 8 different focus group discussions with about 80 different community members. So in terms of the findings from the patient perspective, patients were interviewed and kind of asked to rate a series of positive and negative statements related to their experienced stigma using a Likert scale. And this was a 5-point scale from, strongly disagree to strongly agree. The statements were then kind of divided up into these 4 domains or categories of individuals or groups that either stigmatized or discriminated against TB patients. So these groups were TB health workers, close friends and family members of TB patients themselves through self-stigmatization, as well as members of a TB patient's community. And before I kind of dive into this table here, I just wanted to give you an example of some of the statements that were given to TB patients to reflect on across these domains. So the first example statement would be something like, overall healthcare workers here treat me with respect. Another example is, I'm very careful whom I tell that I have TB. And then also, I feel like I look disgusting because I have TB. And then the last example that I'll give you is the statement, family members keep a distance from me because of my disease. So in looking at their responses to these statements, the Likert scale questions were then kind of converted into scores for each of these 4 domains. And they were adjusted on a scale of 1 to 5, with higher scores indicating higher levels of perceived stigma. So as you can see in the table, the highest scores were actually found in stigma or discrimination coming from the community level, which had an adjusted score of 2.85. This was then followed by self-stigmatizing attitudes among TB patients themselves, and then stigma from close friends and family, and then stigma from healthcare workers with the lowest scores there. So looking at the findings from the provider perspective, this was a very similar activity to what we did with patients. But providers were also asked to kind of reflect on a series of statements using the Likert scale. However, the providers were only asked about 2 different domains of stigma. And so this would be stigmatizing or discriminating attitudes from healthcare workers towards TB patients, and then stigmatizing or discriminating actions or attitudes from healthcare workers towards other healthcare workers who are known to have TB. So like the patient scores, responses from the providers on the Likert scale were converted to a score on a scale of 1 to 5 for each of the 2 domains. And again, with a higher score indicating a higher level of perceived stigma. So you can see from the table here that there really wasn't much difference between the 2 domains, with just a slightly higher rate of perceived stigma seen from health workers towards TB patients as compared to other health workers who were known to have TB. So, the findings at the community level were actually quite interesting and really just had a myriad of information for us, which I would strongly suggest you check out in the link that's in this presentation to the full QTSA report. But I think overall, focus group discussion participants reported that they have witnessed people with TB being insulted, ridiculed, discriminated against, and socially excluded within the community. But interestingly, there seemed to not really be a difference seen between communities that were either in urban or rural settings or across different age or gender groups. Participants from the community really kind of revealed a mixed knowledge and understanding of TB. However, in all of the focus group discussions conducted, there was a very clear link between TB and HIV established among the respondents. And this kind of perceived danger in this link was usually discussed as kind of the basis for stigmatizing actions at the community level. And then finally, when asked about the impact of these stigmatizing actions within the community, there was really a strong belief among community members that stigma from the community was really likely to negatively impact health-seeking behavior of those who had TB or felt that they might have TB. So in terms of the conclusions of this study, as I mentioned, the highest levels of perceived stigma for TB patients really came from the community level. And although the rate was lower, TB patients did also report experiencing stigma from the health system as well. And this was also confirmed by community member discussions who cited hearing about or even witnessing firsthand kind of stigmatizing actions from health workers towards TB patients. Community members felt fairly strongly that individuals would delay seeking care following the onset of symptoms or even default on TB treatment because of either self-imposed stigma and fear, and particularly the fear of kind of being found out within the community as having TB. Overall, I think it's quite clear from the study that stigma, particularly at the community level, is really complex and often impacted a lot by misunderstandings from both community members and people with TB. And this really points to the need for further research in order to kind of reinforce these positive actions and overcome existing barriers. Lastly, I just before I run out of time, I'd like to thank the other authors of this abstract, as well as acknowledge the institutions listed here who were absolutely essential at designing and implementing this research. More detailed information about findings from Uganda, particularly related to stigma, can be accessed via the link in this presentation. And thank you so much for your time.
Hi, everyone. I'm Jennifer Zeck. I'm first going to acknowledge I have no conflict of interest to report. And I'm here today representing ICAP at Columbia University in New York City. And it's my pleasure to present on behalf of my colleagues our study on the feasibility and acceptability of integrating tuberculosis preventive treatment, or TPT, into community antiretroviral refill groups, or CARGs, among people on antiretroviral treatment, ART, in Zimbabwe. So the TB incidence in Zimbabwe is 210 per 100,000. And in Zimbabwe, as elsewhere, TB is a leading cause of death amongst people living with HIV. with a rate of TB mortality more than triple among people living with HIV compared to those not living with HIV. Yet coverage of TPT is suboptimal and completion rates are low. Expanding TPT coverage and completion rates among people living with HIV is a priority of the Ministry of Health and Child Care in Zimbabwe. Differentiated service delivery, or DSD, models are designed to optimize service delivery by adapting the intensity, frequency, and location of service delivery for different groups of people living with HIV. They include facility and community-based service delivery models, as well as group and individual options. In Zimbabwe, one of the DSD models offered is community ART refill groups, or CARGs, in which groups of 6 to 12 people, led by a CARG leader, meet regularly every 3 months, in this case, in the community for ART distribution, symptom screening, and adherence and psychosocial support. At the end of 2019, 11% of people on ART in Zimbabwe were enrolled in CARGs. CARGs may be an opportunity to expand TPT coverage and enhance TPT completion. So ICAP partnered with Zimbabwe's Ministry of Health, HRSA, and the Zimbabwe National Network for People Living with HIV to conduct a rapid assessment of the feasibility and acceptability of integrating TPT into CARGs. We conducted key informant interviews, focus groups, and direct observations of the CARG meetings between March and September 2019. Now, this presentation focuses on the results from the focus group discussions with CARG members. We conducted 16 focus groups with 136 adults in CARGs. Half of the focus groups were with adults who had previously received TPT, and the other half were with adults who had no previous experience with TPT. Participants were recruited from our 7 selected health facilities and conducted in Shona, transcribed and translated into English. A team of researchers conducted thematic analysis using the qualitative data management tool Deduce. We received ethical approvals from Columbia University, Irving Medical Center, IRB, the Medical Research Council of Zimbabwe, and HRSA. Now, these are the participant characteristics, and I'll just highlight a few. That 68% were women, and the median age was 46.5 years. Participants had been on ART for a median of 8 years, and half had been on CARGs for over 2 years. All participants had been in the CARG for at least a year. Overall, participants strongly supported the provision of TPT via CARGs. During the focus group, we presented 3 different models to the participants. Model 1, shown on the graph on the left, involves the CARG member having to leave the CARG for the duration of TPT treatment and going to monthly clinic visits. Once they're done with TPT, they are able to rejoin the CARG model. Model 2 in the middle involves the participant leaving the CARG, or the patient leaving the CARG, for the first 3 months of TPT. And if they're having monthly clinic visits, and if they're doing well after the first 3 months, they're able to rejoin the CARG for the rest of the TPT, and they're in the CARG, they're monitored by their CARG leader. And then in the third model, which was the most preferred model, was that TPT was fully administered through CARGs, and the patients were monitored by their CARG leader, who was taught about side effects and how to monitor during this time. So as you can see, they participants strongly preferred staying in the CARG and receiving multi-month dispensing of CARGs, or of ART and TPT for 3 months, which they would receive at that time in their CARG. We didn't see any difference between the focus groups participants who had experience with TPT and those without. So participants were comfortable being monitored by their lay CARG leaders and highlighted adherence support information sharing, close monitoring, including screening for side effects, cost and time savings, and multi-month dispensing as key advantages. And one participant related to adherence highlighted, I think it is good because when a person is on the treatment and they experience those side effects that we mentioned, one person may decide to default, but when we are as a group, we will encourage each other to endure. Most participants, when asked about disadvantages, potential disadvantages to receiving TPT through a CARG, didn't have any to say. However, a few concerns were brought up, including the increased responsibility for CARG leaders, the potential medication stockouts resulting from having multi-month dispensing, and just the need for additional education for the CARG leaders to ensure adherence and appropriate monitoring of side effects. So in conclusion, people living with HIV and CARGs were confident that TPT could be integrated into the CARG model and felt that education, psychosocial support, and adherence monitoring and screening for side effects could be provided effectively in this setting and monitored by the CARG leader. Participants had been in CARGs for over 1 year and were accustomed to monitoring and medication distribution through this model, as well as receiving multi-month dispensing. So adding another medication was perceived as easy, and the CARGs were actually seen as an ideal venue for them to receive TPT. Participants were confident in their CARG leader's ability to distribute and monitor TPT if they are provided with the right tools and education on TB and TPT. Lastly, I just want to thank my co-authors and the Zimbabwe Ministry of Health and Childcare for their collaboration, as well as for PEPFAR and HRSA for funding this project. Thank you.
Good morning, everyone. My name is Sarisha from World Health Partners. I'll be presenting today. I have no conflict of interest to report. So today's session, we'd like to discuss integrating mental health services into routine TB care in the state of Gujarat, India. And just to give a little bit of a background, the way we're thinking about mental health and TB as a framework is a TB depression syndemic, which is defined as a convergence of 2 or more conditions that magnify the burden of a disease. So if we think about how the physical illness of TB translates to symptoms of depression specifically, we're looking at a mechanism of stigma and discrimination where patients experience stigma from family members, community members, colleagues, coworkers, et cetera, which then translates to symptoms of depression, as well as side effects from anti-TB medication that can translate to mental health challenges, especially psychosis, and especially within DRTB regimens, as well as patients' inability to work, which is often a consequence of expenditure on TB care, also translating to symptoms of depression and other mental health challenges. This is a summary of a protocol that we've implemented in the state of Gujarat in 2 districts. And this is a protocol to integrate, again, routine mental health services into TB care. So we try to screen patients at the point of diagnosis and treatment initiation within the first 2 weeks within treatment initiation at the max. And we had our healthcare workers administer screening tools, PHQ-9 and G87, which test for and screen for depression and anxiety. Again, this is for notified TB patients at the point of treatment initiation. These tools were adapted for 2 reasons. Adapted meaning modified to serve the TB workflows. The 2 reasons being, one, there were a few screening criteria and tools such as a PHQ-9 that overlap with TB symptoms. So we did want to isolate the mental health and depression symptoms separately from that. And the second also is to calibrate the tool for the caliber of our healthcare workers. So instead of just frequency, like never and always, sometimes we added some content to make sure that frequency matched a healthcare worker's ability to assess the patient. So after the screening tools were administered, patients screened as having moderate to severe depression were enrolled in psychological or psychotherapeutic interventions. All these were administered by our healthcare workers and staff, our TB frontline healthcare workers who coordinate routine TB care for patients. And these consisted of brief weekly counseling sessions, usually 6 to 8. sessions, 8 at a maximum. And then after every session, the screening tool was again administered to make sure we were able to monitor the progression of the patient and measure any reductions in symptoms of depression. After that, after we were able to measure any reduction, we also tried to attribute any reduction to whether it was the actual psychotherapeutic counseling sessions that were administered or if it was a routine sort of general well-being of the patient as they progress with the anti-TB treatment, or both. This is an example of a cohort of 9,600 patients that we screened, again, 2 districts in the state of Gujarat. You can see the prevalence here, depression, moderate to severe specifically being about 22%, screen for anxiety being about 10%. So over a third patients or close to a third were expressing symptoms of moderate to severe depression, anxiety, meaning these patients would require enhanced care, enhanced counseling support. And if you look at the right, we also see a higher prevalence among certain risk groups. DRTB, for example, much higher prevalence rate among DRTB patients. Risk groups of patients who were coming from tribal communities, as well as patients who had tobacco and alcohol substance abuse challenges, experience higher rates of moderate to severe depression, as well as patients who are elderly and from certain geographic districts, as we expect prevalence to also vary by geography. So after administering the protocol, after optimizing the intervention trainings, we did examine one cohort of patients more closely to look at the intervention effects and measure improvement in mental health. So we looked at a cohort of about 363 patients who actually completed the intervention, which is a minimum of 5 sessions. About 90% of those patients expressed a reduction in symptoms as per adaptive screening tools. And then 72% of them had a reduction in symptoms the last 2 consecutive sessions. And the key component of this intervention was these include artistic work, physical activity, religious activities, and yeah, can you hear me? Yeah. Yeah. Should I start? Yeah. Can you hear me? After administering the protocol, after optimizing the intervention with trainings, we examined a small cohort of patients for intervention effects with complete data. So we had about 363 patients cohort who actually completed the intervention. We had full, complete data that we wanted to look at. Completed intervention, meaning a minimum of 5 sessions completed. Of those, 90% of patients in the last session, as well as reduction, 72% had a reduction in symptoms in the last 2 consecutive sessions. And a key part of, a key component of, is it on my end or is it, yeah. Yeah, I'm just testing, just intervention effects. Okay. So after we screen patients and also optimize the protocol for trainings, optimize intervention, we examined a small cohort of patients that completed intervention, completing meaning at least a minimum of 5 sessions. So there's a cohort of about 363 patients. Out of that cohort, about 90% of patients had a reduction in symptoms in the last session, and then 72% had a reduction in symptoms of depression in the last 2 consecutive sessions. A key component of the intervention, and especially among patients who had significant improvement in mental health, is what we call behavioral activation, adapted from different psychotherapeutic intervention content. This is where we engage patients very purposefully and intentionally on activities that they enjoy. They're very brief activities like artistic work, physical activities, social interactions if the patient are able to engage with family members or community members, and religious activities. These are activities that patients, the healthcare workers monitored periodically, very intentionally manage their activity timeline and make sure patients sustain these activities over time. And a key component of this, aside from the quantitative data, is also trying to understand what were the different stressors and different types of stressors for patients suffering from depression. And this was a mapping exercise we did. It's ongoing, but one of the clear criteria or category of stressors were medical and clinical. So patients with comorbidities such as HIV and substance abuse challenges, patients who were generally more physically had more severe symptoms, any kind of clinical sort of severity and condition was a major stressor for mental health. Similarly, social drivers, stigma and isolation was a major driver, especially in women who were forced to leave their home by their husbands' families, even if not even within their home, face isolation where they had to use separate dishes, utensils, separate rooms, unable to see other family members. And even if any stigma wasn't imposed on them, any self-imposed stigma, either perceived stigma or any internalized stigma that patients impose on themselves, also contributed as a social stressor to mental health. Economic, patients who incurred massive expenditures in the private sector on TB treatment, loss of job due to inability to work, or complete removal of job due to stigma. This essentially translated to patients not being able to be a primary caregiver, which they previously were, and just being what they perceived to be a burden on the household, also translated to a stressor. Emotional and psychological, these are very interesting sentiments that patients were able to express. There were also stressors, this feeling of why me or why again, especially if you're a retreatment patient or if a patient that already had a comorbidity, why again feeling sort of a compounded burden. What have I done wrong? There's this underlying feeling of being punished or deserving of physical pain or illness, oftentimes in relation to God. So whether you look at it as from a religious context or a cultural context, there's some internalization that the patient feels that they deserve what's been happening, deserve the illness, deserve the physical pain, which translates to apathy and patients not really valuing their health or life. And at a more basic level, it's an information challenge. So patients who have they believe there's a perception of early death due to TB. So especially because TB is a generational problem, patients who have seen their parents or grandparents suffer or die from TB or know a death from a community, they perceive death to be a very real risk factor, which is a stressor for them. And also misconceptions itself, even if they have no direct knowledge of someone who has experienced TB adversely, it's an exaggerated threat in their own mind that also serves as a major stressor. Finally, just how I want to conclude with how we talk about the value of mental health. A lot of the TB program, obviously, we think about metrics around clinical outcomes. We don't think about other quality of care metrics, especially related to mental health. So some discussion on what that might look like, and also how we might improve a reduction in the severity of these mental health challenges, what those metrics might look like, and also documenting the patient experience of these both mental health challenges and the services that are trying to address these challenges. A lot of times, actually, there's no vocabulary for patients themselves to articulate a mental health challenge. A lot of it hasn't been internalized yet to be able to actually for the patient to be self-aware about it and then reflect it back to someone else, a healthcare worker, is very difficult. So just creating a vocabulary and a realization around it is that itself is a challenging exercise that we want to be able to lay some foundation for. And then finally, a threshold of evidence to integrate services, specifically into national guidelines. So as we provide patients with treatment regimens, alongside that, actually be able to provide mental health services as part of a technical operating guideline with equal priority, with equal intention and intensity and accountability. So that's what we're aiming for, hoping to end the session with actually being able to integrate services, mental health services into TB care. Thank you.
Good day, colleagues. Our presentation in this track will review how the programmatic implementation and the related referral and management practices of DRTB in South Africa evolved because of the global and local move towards the decentralization of DRTB diagnosis and treatment. We'll also look at how our model developed to incorporate person and family-centered care. Our talk is entitled Journey Patterns and Models of Care Observed in Patients Receiving Drug-Resistant TB Treatment in South Africa. And we're essentially looking at the organization of care delivery for drug-resistant TB patients. Determining healthcare delivery models for patients and multimorbidity is a challenge. Drug-resistant TB is a complex condition with frequent comorbidities. To upscale and improve disease management, DRTB treatment has shifted globally towards community-based care. A national transition from a hospital-centric approach to a decentralized model of programmatic DRTB care commenced in South Africa in 2011. And since then, the local adaptation of the policies varied, and it was uncertain as to how patients were moving in the system and which models of care had evolved. A retrospective observational study in 13 high-burden urban and rural districts within 3 contiguous provinces in South Africa took place. Patients with DRTB were sampled from routine state laboratory records from July to September of 2016, and care pathways for 191 randomly selected patients were reconstructed using patient lab sample data, folder record review, and facility staff interviews. So the methods were that we took all new patients drug-resistant TB, RR-TB lab tests in study districts from Q3 of 2016. We received 2,649 patients. Eligible patients were randomized and then selected sequentially, 15 per district. The contiguous provinces we selected were all coastal provinces, and they were of the Western Cape, KwaZulu-Natal, and the Eastern Cape. We selected 2 rural and 2 urban centers in each district. And in KwaZulu-Natal, we had to sample an additional rural district because at that particular time, the rural and urban mix was in flux due to the shift of the international airport. So we ended up with 191 patients who we could identify some delivery model. And those are normally patients who had at least one journey that was made. Most drug-resistant TB patients in the sample were African males between the ages of 20 and 40 years. They resided in cities or small towns. They had some secondary education and no personal income. 14% reported some correctional service use history. 69% were HIV positive. 63% had other comorbid conditions. 63% had previous drug-sensitive TB, with 10% having previous drug-resistant TB episodes, and 47% of those were diagnosed on second-line DST with an MDR-TB. Spatio-temporal mapping of patient care journeys and identification of common pathway patterns occurred in the methods. Our patterns provided structure to describe the associated service delivery models, and models of care descriptions were supplemented by facility visits and staff interviews, and these were verified by a national DRTB stakeholder feedback session. As you can see, I just mentioned step 3 and 4. Initially, we obtained literature and consultations in order to provide substance and provide some policy appreciation and some understanding so that we could go about the patient journey mapping, where we underwent this patient pathways and journey mapping in facility. So Stokes' Foundations framework was then used to analyze the models of care for patients with this multi-morbidity that I've described. The Stokes' Foundations framework comprises of 2 aspects of the foundations. These were the theoretical basis and the defined target population, and 3 elements. This was the organization of care delivery, as highlighted in yellow, which we shall focus on, and also the support for model delivery, as well as there being a clinical focus. And this framework provided a comprehensive tool for reporting the models of care, and it was chosen since DRTB is not typically a single disease, as we've alluded. The reasons behind patient movements, which was political challenges, patient and family centeredness, infection transmission risk, resource availability, digital technology utilization, and other aspects were all explored. So as you can see, this is the pathways or the journeys that we were able to find in these 6 different models of care that we were able to identify. We looked at the district distribution of where exactly these patterns took place around Southern Africa in the 3 provinces that I alluded to. And we also then outlined the actual models of care, and we portrayed these in small pictorial descriptions and the movements between each of these facilities in the models of care at the base of the screen. So as you can see, if we focus on these patterns a little bit closer, the majority of patients were managed in the 3 more centralized care models, and those are in the orange towards the left. These models had the longest time to treatment initiation, the longest in-hospital stay durations. Patients in the 2 most centralized models, they traveled the furthest distances from home compared to patients in the most decentralized models, which were furthest to the right within the first 9 months of care. There was a marked reduction in retention of care between month 4 and month 6 following treatment initiation in all the models. Treatment status at 2 years was variable within and between the models. The chicken foot model may be the least favorable overall across all variables. The others all had differing benefits. The line and triangle models offered patients the most flexibility in terms of DRTB care options. Thereafter, the pathway pattern data was verified by 79 respondents representing all the study provinces. Of the respondents familiar with the research areas, 78% of KwaZulu-Natal, 86% of the Eastern Cape, and 81% of the Western Cape agreed with the representativeness of the patient pathway patterns. And despite the actual hospital admission duration being much longer, 75% of these respondents suggested admission duration should really be between 2 days and 2 weeks, and this was mainly to achieve patient medical stabilization. 65% agreed that the DRTB decentralization program had provided an opportunity for more family-centered care for both parent and child and patients, with 17% being unsure and 17% disagreeing. So our conclusions were that the patient journey pattern analysis using laboratory data can be used to determine how organization of DRTB care has evolved in a health system. Using spatial temporal patient movement patterns, health managers can understand pathway and referral patterns in their regions. They can investigate care models and seek ways of improving the patient and family experience, as well as monitoring decentralization. Involvement of a greater number and spectrum of facilities creates capacity for greater range of care and referral flexibility, and this helps patients to travel less, which benefits infection control and patient safety and cost. And the strategies of connection, mainly digital technology, can help bring the expertise closer to the patients and combine the energy, innovation, and resilience of decentralization with the knowledge, ideas, and experience that comes from centralization. And the tailored patient and family-centered, culturally sensitive care packages should be provided to suit vulnerable patient groups within each of these models. Now, in describing and analyzing the models, there became a need to modify and further enrich the Stokes' multi-mobility framework lens. And to this, we added patient and family-centeredness, the context, the environment, and digital connectivity. And the adaptation of Stokes' framework helps to examine models through a lens that acknowledge and emerge from what it takes place within the context of a developing country with provincial and district differences, all within unique but overlapping socioeconomic, political, environmental, legal, historical, and cultural contexts, with a common aim to organize care delivery within the goal of decentralizing patient-centered DRTB care. We'd like to acknowledge our funders and our sponsors, as well as people who participated and provided so much input into our care. And we'd like to acknowledge that this UK-funded award is part of the EDCTP2 program, which was supported by the European Union. Thank you.
The title of presentation is Implementation of a Supportive Care Package to Strengthen Drug-Resistant Tuberculosis Patients' Adherence to Treatment in Xi'an, China. The reference number is 0809555521. My name is Zhao Ali. I'm from Xi'an, China. Next slide, please. Background. Treatment of multi-drug resistant tuberculosis is complicated and challenging due to the length of the treatment, severity of disease, limited patient understanding of complicated regimens, social stigma, and huge financial burden. In China, the treatment success rate for the 2016 MDR-TB cohort was only 52%. Xi'an Chest Hospital, a provincial-level MDR-TB care facility in Shanxi Province, Western China, implemented a comprehensive supportive care package for MDR-TB patients from February 2019 to improve outcomes. Next slide, please. Interventions. First, face-to-face and online education and counseling for patients and their families. Second, group activities are held once a week with a variety of themes. Group activities mainly focus on the basic knowledge of the MDR-TB and the significance of regular follow-up visits, how to properly deal with adverse drug reactions, and how to protect family members from infection. Third, the main form of peer work include daily assistance, online service, inpatient DOT, and group activity participation. Next slide, please. First, MDR clinical management system. Through the case system, consultants can remind patients to return to the hospital on time every month and timely records the examination items of the patient, which is helpful for the medical staff to manage the patients with MDR-TB. Fifth, Xi'an Chest Hospital established working groups internally and with local CDC and communities to address emerging challenges and facilitate coordination to implement the package. Next slide. Results. G-square test was used to compare 176 patients diagnosed between March and August 2019 with historical pre-intervention group of 155 patients diagnosed in the same period in 28. By the end of January 2020, the 2019 cohort performed better in terms of the treatment enrollment. 96 point versus 89.7%. The treatment retention for at least 6 months was 85.2% versus 73.3%, and last to follow up was 5.3% versus 19.4% as of January 2019. Patients in the 2019 cohort was also completed 95.8% of the required treatment monitoring visit scheduled from March to August 2019. A 16.2% increase from 82.4% for the 2018 cohort. Next slide, please. Conclusions. Preliminary data suggested that a supportive care package effectively stressing the patient attention in MDR-TB care contributed significantly to reduce loss to follow-up and stress in treatment adherence. Expansion of this package to other sites in Shanxi Province, Western China, could increase successful treatment outcomes for many individuals with MDR-TB. That's all. Thank you.
Thank you for your presentations. Or to all speakers, we now go to the question and answer, and I give the floor to my co-chair, Surinder Temni.
Hello there, everyone. There's a slight delay there. We will now move to the questions, and we have a couple of questions from Moses. And I think what we'll do is, for one, to answer live, Moses. Are you there, Moses?
Yes, I am, loud and clear.
Lovely. So if I can present this. Okay, so thank you, Moses. And I have just posted a question to you to answer live. Did you receive it?
Negative.
Okay, so if I may ask you, a question that was posted from Yoen Sobiak, and many thanks for the presentation. What are the current efforts to engage private sectors and expand TB diagnosis accessibility to lower level of health system? Moses, would you like me to repeat?
No, I got the question. Can I
Thank
answer
you.
now?
Yes, please.
Right. Thank you very much, Yoen, for your question. Currently, what we're doing with the private sector is right now, from the head of state commitments made at the UN high-level meeting assembly, we are engaging the multi-sectoral accountability framework, which is in the process of being rolled out by the Office of the Prime Minister. That is one intervention which will directly impact on engagement of the private sector as a whole. In the development of our national strategic plan, we specifically went to the Private Sector Foundation of Uganda and manufacturers, as well as private health providers. Together with Uganda Stop TB Partnership, we are coordinating the private sector mechanism. We've also revised our health facility accreditation guidelines to engage private sector in accreditation to deliver diagnostic and treatment services for tuberculosis. And also we are in the process of enrollment, increasing the enrollment of private facilities reporting for tuberculosis from the current 20% to at least 50% within this performance period. So those are some of the interventions we are looking at. And also we want to provide diagnostic capacity for the private sector in terms of enrollment on the diagnostic network. We have, for example, chest X-ray vouchers that are being provided so people in the private sector can have a cash payment for services provided to patients with tuberculosis, for example, chest X-ray. Thank you. Over to you, Chair.
There were also some questions for Nikki, and one of the questions I will publish now. Very interesting findings from, thanks for the presentation from Anka Vasiliou. Thanks for the presentation. And have you seen Nikki?
Thank you, Moses. Hello, Nishay. I think you've just presented a question to Nikki.
Yes, I did, but yes, I did, but I do have problems with the with the for not ice. Very interesting findings from thanks for the presentation from Anka. Vicky?
And 3, 2, 1, over to you, Surinder.
Thank you. This question, Nikki, is being presented to you, and it's from Nona, and very interesting findings, especially about stigma towards healthcare workers.
Yeah, sure. So I don't have a great answer for this question because it really was not the focus of our study at large. We didn't really dive deeply to try and understand what were the causes of discriminating or stigmatizing attitudes towards healthcare workers, but really what we were asking was we were asking of TB health workers, what was their perception and what were the observed attitudes towards their fellow colleagues who were infected with TB. So it was a really high level kind of look at that without doing the big deep dive. But I think it would be a very interesting question to answer in future research.
Especially about stigma towards healthcare workers.
Yeah, sure. So I don't have a great answer for this question because it really was not the focus of our study at large. We didn't really dive deeply to try and understand what were the causes of discriminating or stigmatizing attitudes towards healthcare workers, but really what we were asking was we were asking of TB health workers, what was their perception and what were the observed attitudes towards their fellow colleagues who were infected. So it was a really high level.
Okay, lovely. It would be an excellent question, so thank you for that. Okay, so Nisha, are you still having problems? I'll keep going. Okay, let's try this way. So I'm going to go to Jennifer. In your presentation, it suggested an increased responsibility for CARG leaders. I was just wondering about the impact on their motivation because of the increased responsibility and how these leaders were being supported.
Hi, thanks for the question. So this was just asking their view on how this increased responsibility would impact their work. The main takeaway we got from the CARG leaders is that if they were provided support from the health facility, they feel very confident that they would be able to provide TPT within the CARG groups. So with the appropriate support and education and training, they're very confident in their ability to do so, since they had
gone through the training of providing HIV care. And there are some pilots right now of actually implementing this. So we'll see kind of what the takeaway is from the CARG leaders on their change in responsibility and their motivation.
Their view on how this increased responsibility would impact their work. The main takeaway we got from the CARG leaders is that if they were provided support from the health facility, they feel very confident that they would be able to provide PPE within the CARG. So with the appropriate support and education and training, they're very confident in their ability to do so, since they had gone through the training of providing care.
Yeah.
And there are some pilots right now of actually so we'll see what the takeaway is the CARG leaders on their change in responsibility.
Thank you. Thank you very much. I'm going to move to Sarisha now. There was a question posted by Tyler Dugan. Were you able to compare with the prevalence of depression among the general population in Gujarat? Answer live, please. Sarisha, are you there? Did you get the question? Would you like me to repeat? I will repeat.
I'm going to move to Sarisha now. There was a question posed by Tyler Dugan. Were you able to compare with the prevalence of depression among the general population in Gujarat? Answer live, please. Sarisha, are you there?
Okay. I think we shall move on.
Did you get the question? Would you like me to repeat? I will repeat.
Okay, so what I think I'll do is we can, I think, move to Lindy. And I think there was a question from me. It's you noted the local adaptation of the policy varied. With what you've concluded, what is the certainty that there will be a reduction of disparity of implementation of a person-centered approach? Over to you, Lindy.
Yes, yeah, there were two questions. One was actually asking me about the decentralized, if the decentralized model was working well, if those patients retained in care. And I think I answered that on the chat, that the patients in the more decentralized models did actually do very well in terms of their outcomes. They were generally patients who were more well, but they certainly did retain in care better. They had better patient satisfaction scores, which I didn't illustrate here. They interviewed. They were more, yeah, they had better experiences. They had better sort of connections with the local sisters, and they were able to eat and spend time at home and, you know, walk short distances to get their treatment. So they certainly did well. Then with regards to, you mentioned about the models of care, just repeat that question a little bit for me at the end.
the patients in the more decentralized model did actually do very well in terms of their outcomes. They were generally patients who were more well, but they certainly did retain and care better. They had better patient satisfaction scores, which I didn't necessarily hear the interview. They were more, they had better experiences, they had better sort of connection to the local sisters, and they were able to eat and spend time at home and walk short distances to the treatments. They certainly did well. Then with regards to, you mentioned about the models of care, just repeat that question a little bit for me at the end.
I think the fact sometimes it's about a person-centered approach to support and care. What happens on the ground to ensure that services are able to support patients in that way? Really, we're talking about resources in terms of patient support and helping them to adhere to treatment.
That's certainly a challenge, and it very much depends on where you're at and the level of resources and the demand for those resources in different settings. Certainly, if in accordance to our package of patient services, we do have, at least on paper, psychologists, social workers, social support and financial support agencies. And we also have clinic and nursing staff who assist patients with understanding what their treatment implies, working together with the other services such as HIV and art services, as well as trying to incorporate the patients into other chronic care services like for hypertension and diabetes, etc. But certainly in some areas, they're able to do that very well. They have staff and they have the time and space for those patient sessions. And in other places, not so much. Also a difference between rural and urban and between the provinces. What we also find is that in the very beginning, sometimes this is done fairly well. And then as patient treatment and management continues over time, patients are expected to sort of, just sort themselves out, which I think was particularly problematic in the older days when patients were on a 2-year regimen. But with patients now having a shorter regimen and on treatment for 6 to 9 months, I think that the patients and the staff themselves are able to spread themselves a little bit more generously and give patients a really good sort of boost in the beginning and hopefully not lose too much speed and energy towards the end of the treatment, and actually retain patients and try and give patients as much of an individualized, patient-centered journey as possible. We don't always get it right.
Well as trying to incorporate patients into other chronic care services like for hypertension and diabetes.
Right.
But certainly in some areas, they're able to do that very well. They have staff and they have the time and space for those patient sessions. And in other places, not so much. Also a difference.
I've lost connection here. Okay, can you hear me?
I can.
Okay, thank you. I lost you a little bit there, so apologies for that.
No problem at all.
And what I think what we will do is post all the questions to all the speakers, so to make available all the answers and post them somewhere. I will discuss that with Nisha. And I think we still have time for one more, Moses. If I may come to you. Are you there still? Can't see you.
Yes, I am.
Yeah, thank you for your patience. So Moses, there was a question about specimen transport. Were specimen transport networks considered in the calculation of coverage of diagnostic services or any availability of on-site testing services?
Thank you very much for that question. Initially, the service and readiness availability assessment did not take into account the hub rider system that we have currently. We only have a national system for transportation of samples for second line resistance patterns testing, and currently under the new the current implementation, we have the hub rider system whereby partners pick up transportation samples from lower level facilities. This was more or less mapping out the facility best. But if you can notice, most of the private facilities are not involved in the hub system transportation, where most of the population first seeks care. So there is a gap in the sense that the private facilities where most of the population comes to for the first time, they are not picking samples from the patients and sending them to facilities that have diagnostics. So that is one area we realized was a gap. So our engagement is going to focus on specimen transport or patient referrals to the centers that have diagnostics. Thank you. Over to you, Chair.
Thank you very much for a very comprehensive response. I think now I'm just going to be going through whether we've missed any questions that have been posted, and I think majority have been answered. There was many for Sarisha. And I think that's about it. I think unless the speakers have any questions they would like to present to one another. No? Okay. I'm having problems accessing the answered bit, but I think if that's agreeable to everyone, we'll post all the questions to you and then make available your responses to those who took part in this session. I'd like to thank everybody for an extremely interesting and motivating talks, and it's been inspirational and demonstrated the commitment and the passion to get things right for people who are affected by TB. So once again, thank you all so very much. I hope you enjoy the rest of the day and the conference throughout the week. Thank you.